Operation should take 3 hours. Patient should be touching across. Blood should be in the room. Equipment's been reviewed with me and Mirtha. Craniotomy. Make sure we have gel foam in case we have sagittal sinus. Blood should be in the room. Safety precautions of the med patient felt and included. Correct. Antibiotic, anti-epileptic, Decagon, mannitol. Patient will go to the ICU post-op.
Dr. Lang, procedure confirms via consent. Patient is under general anesthesia with infiltrate. He has adequate venous access. He has invasive pressure monitoring. He received his antibiotics and Keppra as well as mannitol and dexamethasone. Pressure is 140 heart rates in the 70s. As for the integrated blood, he's in room stream. It's 1 exclamation to the ICU afterwards.
Right side, sterility is confirmed.
Right side, they're still preparing blood. We'll send for as soon as it's ready. We have independently collectively identified the patient by name and birthday without any discrepancies.
All right, let's take a moment to be mindful. We call this the mindful moment. We all pause and bring our attention to our own breath. Together, we're going to take 3 deep breaths in through the nose, hold at the top, and exhale through the mouth on your own time. All right, let's roll.
All right, everyone. That was the mindful moment portion of the case. We're going to get things going now. I'm not sure how the sound is. It's going to be a little bit difficult to hear at times. We're going to try to talk our way through it as we go and operate. This patient presented with a large right frontal meningioma, and I'll pull up the films for you guys in a second. I also have a component of a talk that we can give just talking about what meningiomas are. This is kind of the beginning of the virtual OR. So for now, we can leave the chat open. I'm not sure we're going to be able to respond to you guys because we'll be operating. But let me go through the films. All right, it's going to be a little difficult, so if you can't hear, let me know.
Here, I got to scrub next door briefly. Go ahead.
So I don't know if you guys can appreciate this or not, but this is a little tough to see. We're looking at up here where the mouse is, a large meningioma. It's considered parasagittal based on its location, pushing right in front of the motor strip and mainly in the frontal lobe. So these are benign lesions typically. They grow off the dura. They originate in the arachnoid cap cells. And in general, they do not infiltrate the brain, although that is possible with more aggressive ones. And so the goal here is to resect as much as possible. If you get a total resection, the patient's cured. But actually, with a majority resection, there are treatment options, things like radiation that can control the spread. So ultimately, the goal is to keep this person, one time on the operating table and hopefully cure him for life. You want to add anything, Dr. Brookbar?
No, make sure your hands are clean. About less than 10% of meningiomas have what we call an aggressive characteristic, meaning they can have some atypia. So one of the important things, particularly in the young guy here, is to make sure he's not one of those 10% of patients that have an atypical meningioma. An atypical meningioma would require post-operative radiation therapy in addition to surgical resection. So as Dr. D'Amico said, we're going to go in, take out as much of this, if not all of this, as possible, spare the big draining vein of the brain called the sagittal sinus, and then hopefully he has what's called a grade 1 meningioma, does not require any post-op therapy, and lives a normal life. Biggest risk of this operation for this guy is weakness on the left side. Remember, right brain controls left body. So he has symptoms where he will shake out his left arm and he can't really feel that left arm well. So we know that he's having problems with that left arm already. So we're going to try to avoid that.
Yeah, absolutely. I'm going to mute you guys just for 1 second. All right, guys, so what we're going to do now is come inside. you can see that actually surgery started. And so they've done an incision, all right? And I don't know if you guys can see that there. And they're preserving a lining on the covering of the bone called the pericranium. Pericranium will be used at the end of the case to help with a watertight closure. All right, I'm gonna actually set you guys up. I'm gonna kind of help move things along so we can at least get to the tumor portion of the case. And so I'm gonna mute you guys a little bit while you watch. And you know what, I'll leave it going. We can talk through it. So, is that a reasonable spot there? I hope so. And then again, I'm gonna give you guys some education when we're done in a little bit. They can see enough.
Where you from?
I grew up in Cleveland.
I know if it's a Cleveland, I don't know why I did that, I'm sorry.
What? Oh, you said Tulsa?
Yeah.
No, that's not. That is rude. What kind of shit is that? So I'm trying. Yeah, okay, so see that? That's the pericranium. It's later a periosteal fascia that just stops the bone, covers all bones. And it's nice to use because it's a vascularized piece of tissue that you can put on top of dura or any other defect that we create that helps to heal and start over so we prevent kind of case stuff. All right, can I get those Randy clips again? I'm sorry, I knocked them all off. Galea? Galea is, yeah, it's below the galea. The galea is the aponeurotic layer. Now, this is galea here. See this thick layer? That is what we use
No, not yet.
to close the scalp. Can you do it here?
You push that nail stand a little bit closer. Not too much closer. But apparently it's hard to see the bright light on the brain.
There, right. You're gonna put the Mayfield thing or the Andrew thing? Actually, don't know how to use it.
Let me slip in here, bud, if you don't mind. I'll help out. Hey, everyone, I heard it's a little bright. You'll get to see more in a little bit. We're just going to help move things along. Like I said, we're preserving the pericranium here, which is a soft kind of mobile layer on top of the skull. And that's going to be used to repair the dural defects. Since this thing grows in the dura, you want to remove as much dura as possible. Heavy curve mayo? So first things first, use everything.
We can go
Yeah,
probably
get it all the way.
Have a knife.
Because this is big. Yeah. We need to retract it. Come all the way down to there. Kobe.
Have a knife back.
Thank you.
And so what we do here is we're just opening up the skin. And then the same thing over here. And that back over here too. Take it all the way in here. We need to retract it. Yeah. All right, heavy curve now. So the way to do that basically is you have scalp, you've got a layer of fat, and then you've got galea, which is the tensile layer of the scalp, and then pericranium is on the bone itself. And so what you want to do is separate the scalp from the pericranium, and that'll give us some room. Also help us mobilize everything. Come this way, okay? And use your finger to really separate. I think it's going to be a big defect. I think finger is going to be the safest, most blunt instrument. We have a bent bovie or not yet?
You want to bet now?
Yeah, let's get a bent one now. Every second. You want to recall the back of the bent bovie. You want to cut this entire circle of pericranium out. You get more over here. You got that. I think I got most of it. Let me see an Army Navy. So what we're gonna do? Can you guys see us? Probably endoscopic. Oh man, there's so many questions. I want to answer all these questions to you guys. We'll go forward first. Let me see a second Army Navy. What questions? So basically what we're going to do is we're going to elevate the scalp here that's now separate off the bone. He's going to go as far forward as he can without cutting through the skin. You can start wherever you want. You can start with bigger, go deep. And he's going to take a big, basically, sheet of this stuff off the skull. And it's going to shrink down. But at the end, just take that out for now. Just walk around with it. At the end, we're going to be able to stretch it out and use this to cover it. So go take it as far as you can. Get as nice as you can. I'm sure it changes up. I want to take a heavy pickup as well, just to get this whole range put out of here. Beautiful. Okay, we're coming around. Along the bone edge here. Okay, Oscar. Nice. Now what you'll see is we'll be able to elevate this out of here.
Make it more saline.
Usually stick most of it to your capital plan.
Yeah, it's coming up.
Well, usually you complain I overdo it.
You got more rainy clips?
You can give the ring.
Thank you.
I'll take the bovie back.
It's like a heavy pickup seat.
I did. Don't mind him.
I do.
Nice. So we're just replacing those hemostatic clips just to make sure that we have good hemostatic.
Can I get some more rainy clips?
Bovie back. Heavy pickup now. So if you get stuff for me there.
Okay.
You guys see this big swath of tissue coming out here? This is actually the pericranium that we're elevating. Start to see the nice sheen of the skull.
You got another rainy gun?
My fault.
No, no. It's,
There you go.
one sec, I'm sorry. I just want to make sure you have that.
And so you can actually see some what's called hyperostosis in the bone here.
Yeah, look at that.
And that's associated with meningioma growth. They promote growth. You're going to straight up. Hold on to this.
We're going to give you a pericranial flap in a sec here.
Thank you. You might need to pull down up there. So this is pericranium, this tissue flap that's coming out right here, okay? You good? You're good there. All right.
Let me get that rainy gun again.
Let me see a bayonet. So this is pericranium. This is a piece of the covering on top of the skull that we're going to use as a dural substitute at the end of the case. And like David said, this is his own tissue. So this is this is, autologous skin graft basically that'll cover the dura there as we remove. So here's your flap. I'll take a return. Cerebellar. So what I was mentioning before is that there's already hyperostosis seen. So the bone is actually grown, and that's due to the osteopromotive effects of the meningioma underlying it. Very, very common. All right, so that's skull, and right here, I don't know if you guys can appreciate it or not, but there's a bony abnormality. So our tumor is right there. You see the wand? Dry sponge and a marking pen. So this is neuronavigation. So this uses with millimeter accuracy, based on its preoperative MRI, we're able to identify exactly where the tumor is. We register that based on the scalp. So what you see here is the tumor on the screen. So what is the marking pen? Move forward, right? That's the front of it, right? Up there. Great. Again, we're going to end up pulling it in. So that's going to be where our front is. Right. I mark the midline typically in 3 places. That's like my safety protocol. Yep. So 1, we'll mark it there. 2, we'll mark it there.
You have another cerebellar or a Wheelander?
3, we'll mark it. I want to see the back of this thing, which is actually going to be far back. It's going to be basically here. Like this is probably good. All right. So let's open the skin a little bit.
This is midline, is it?
That's midline, man. That's going to be the front. The back's going to be further back.
A few burr holes over here.
So I don't think we need to cross the sagittal.
Oh, you know.
Yeah, did you say you wanted to?
Yeah, he said burr holes across it.
You did want to go across?
Yeah.
Okay. We'll go across.
You want the cutting board on?
Oh boy.
So then what I would do is I actually do slots. Let's do slots. So we've marked out where the tumor is. We have to mark out the middle line. This is a parasagittal meningioma, which means it occurs growing right next to the superior sagittal sinus, which is the main draining vein for the brain, basically. And so now what we're going to do is some bone work. And this is going to be a little bit boring. We're going to pay attention. We have to be very careful about the superior sagittal sinus so that we don't cause any injury on it. So sit tight, all right? Tumor's coming. All right, here. I'm going to have...
All right.
So what does he do? He does verbals on both sides? I learned how to do this. I slot typically. Let me see a skin knife.
Let's see. Hey, Carolina.
Yeah.
Sorry, Carolina. This, like North Carolina.
Will this page on you or no?
Oh, no. Oh, thank you. All right, so let's see. This is anterior border, posterior border, lateral. You want to do the revert? Yeah. Put a straight up. All right. Well, perfect. All right. So you got our plan. So you're up. Drill. You want to flank? So I do slats. Okay. Man, that's kind of the way I always learn to do it. The way to do slats is just go a trough here and a trough here, basically.
Oh, okay.
Not perforated.
Yeah, I just use drills. That's it. I'll do the first one, then you do the second one. I'll show you how to do it.
Very good.
Table up about 3 inches.
Now we got 3 inches.
Hold on.
Thank you.
Not yet. I'm feeling extra salty.
Nice.
You see the coronal suture.
Yeah. Table up yet or not yet?
Go ahead.
Irrigation.
Oh, yeah.
Okay.
Thank you. That's good. Sorry, guys, I'm gonna block your view for a second.
Curiosity.
Basically, I get a cross on across the top of it, right? And then I do a piece of a burr hole on the top. So that's already good, right? We're through there. And then get another burr hole, just on the other side, so I can find burr there, right? And that means I know my depth, right? And then yellow goes here. I have some bone mass available.
Yeah.
Nothing through cross, that's it.
And your finger on
All
six.
nice and thinned out, right? Halfway bone. You see a straight through it. Take that back. Then I'm going to take a kerosene tube. Hey guys, we are going to be over the superior sagittal sinus here. And so there's a risk of, slight risk of air embolism. Kerosene 3 now. First one on the put them up to the
You see that? Where I am.
More irrigation. Beautiful cross. So now you do the back one, right? And let me see, a little worm of gel foam or a square of gel foam or something. And a small cotton hood.
I'll take that.
Bigger than that, sorry. I'm used to Langer's speed. Perfect. All right, so let's go ahead and get the back one. I'll take an Army Navy to me.
I'll take that swirl.
All right, so we've got the first bird. What are you doing? This isn't your job. Caroline's holding the camera, but she doesn't have to. You see irrigation to me also. So this back mark is actually right here. So if you're going to be, yeah, exactly, just like that, right? Just be careful with the sign. Put it back down. It's okay that they can't see this bird.
That's my hand.
That's fine. I'm not going anywhere. So we're still drilling. We have to do a few slots over the big vein, and then a burr hole probably. And then we'll take the bone off. Now the bone is going to be attached to the tumor. As you can tell by the way that it's grown through it a little bit. Try to make it just the width of the burr. Once you're under the cortical bone, then you can widen underneath, and that way the closure is nicer. We're good.
Are we live?
Yeah, we're live. I do troughs. I'm just more comfortable that way. Yeah, we'll be ready in a second for you.
Some bone wax.
So what I want you to do is now get your depth out here, right? You're over tumor, you're over normal brain, and you can find dura down over here. That's going to be thick because you're right over motor strip, right? Some more irrigation, please. Little wax on stick. Take that. Or here, finger wax. You got finger wax? Perfect.
My wife's asking if the lighting could be better.
For the OR? I'll fix it once I get out. All right. Double ender. Perfect. Watch yourself. Here you go. So this is all hyperostotic bone, right? That's what you gave me here. Irrigation. So you're not through there. Yeah. Good. So this is the boring part. Sorry, guys. You can see, right? You got good visualization. Let me see wax on a stick or wax on a finger again. These are called emissary veins that we're dealing with here, and they're a little hyperostotic because of the tumor. It's kind of parasitized the vein. Double ender back. Right, how much do I love a double ender?
Not as much as others.
Ellis loves it too. It's like the universal instrument. It's like
It was the Columbia thing.
totally the Columbia thing. Irrigation there. Just handle that midline portion for right now. Tear that down a little bit. Tear it down here. Tear it across the side. Is that me? Perfect.
Good morning. This is.
You can. It's unmuted, right?
Yeah.
So we've got the posterior slot now, and then we're going to take the bone off in a minute.
And then what do you like to do? You strip under here, you burr holes out
Yeah,
here?
I'm actually, what I usually do, I mean, I'll show you, but JB's in, so I'll probably scrub out and let him go with you. I actually usually just run the foot plate to here, turn it 180 degrees, pull it out, run it from here to here, and then down there. Right? You never want to drill towards the superior sagittal sinus. You always want to drill away from it. And that will get you a nice clean exposure. Difficulty here is going to be the tumor is going to be stuck to the superior sagittal sinus right here. All right? And so you have to be super careful not to unroof that. Super careful. It happens. Kerosene tube.
Yeah, good luck.
Kerosene dose. Thank you. A little bit of suction here, please.
Navigation.
Suction, yeah. Kerosene 3.
Josh, is there blood in the room?
Did you hear more about the board?
No.
Or I go across the kerosene for safety.
Thank you.
Okay. Can I see the drill back real quick?
Just down right there.
Hmm?
Lying back.
Hey, Bondo, are you still here?
I'm here.
Can you give me a
My
little
headlight?
light? Yeah. Just look down here. I'll be right back.
You want the right here?
All right, kerosene back. Thank you. Okay, let's put the foot plate on the drill.
Josh, when I say so, could you bring the head up and the table down, please?
Here, can you move this back, this stand?
So,
I'm gonna stand right between them so I can get my headlight on them.
Head up now?
Keep moving. Just move the whole thing.
Yes, head up now?
yeah, head up now.
Yeah,
Table down.
Thank you. The drill back, please. I usually just run it and turn it there.
I'll take most one then.
More irrigation, please.
No, I think we do.
Your head of the bed ready?
Potential three.
I'll take a pencil one.
Before we do this, let's have a bunch of flow seal. Gel foam.
Give me water, dry, dry, why dry,
I did it right. Yeah.
And the blood's on your leg. Check that.
I want to see why gel foam like natty.
Yeah. Got it.
Got it. Josh, you're the head of the bed. Okay. I'll do a pencil one.
I'll just make this
I'm getting Carolyn.
Nikki
Nikki
is
is coming.
That makes sense. Makes sense.
Got a pencil three now, please.
And then go through Nancy.
Oh,
So right now, Dr. Bookbar is lifting the bone flap up.
He's actually dissecting the tumor off the bone.
the blood is here.
The blood is here.
Verified.
We're okay right now.
It's really high.
Is baseline time?
Yeah.
No. Good baby back? Yeah. Okay.
Pencil one.
Okay.
You can take a bogey on the inside, just cut it.
No, they don't.
Irrigation.
The bone flap's off.
Yeah, maybe they're.
Big wash.
Got a dry spot, please. So you can actually see this tumor actually invading bone here. So we're going to drill this off later. Take some of that tumor out of the bone.
Bone wax.
Yeah, exactly. Yeah. All right, guys. So that's the beginning of the opening. All right. So now while they get things cleaned up a bit and expose the tumor, I'm going to talk to you guys a little bit about meningiomas, and then we'll come back in when they're under the scope. All right.
Irrigation, please.
All right. So, what do y'all think so far? I hope you guys can see a little bit there. It's a little bit tough. I'm going to pull up my talk real quick and then I'll share my screen. Give me one sec, guys. So that's something called a bicoronal incision, just while I'm pulling this up. And that allows us to get over the superior sagittal sinus, which is right in the middle of the head, right? And, sorry, one second. Returns, presentations. And that's an important vein because that actually, all the veins basically above the tentorium feed into that and it drains down through the venous system. And if you were to injure it, not only can you have massive bleeding, but you can also end up with venous infarcts. A lot of people talk about stroke, right? And they talk about arterial infarcts, which is when obviously an artery is occluded. But you can also have venous infarcts, which cause the same issue. Basically, the venous blood backs up and the brain swells and ultimately infarcts. Can everyone see my screen? Hopefully. All right, so meningiomas. So the big key concepts here, we talked about most of this. This is actually the most common primary intracranial tumor, okay? They're benign, they're slow growing. We talked about intraaxial or extraaxial. These are extraaxial, meaning outside of the brain itself, okay? And like I said, they arise from these arachnoid cap cells, which are within the dura, which is, again, the dura is the covering on the brain. And dura mater actually means hard mother. And if you were to feel it, it's very leathery and very, very, very strong. And so they grow from this, and they typically have a very wide base, and they actually push normal brain out of the way. Typically, when you look on a scan, these are going to have this broad-based dural attachment with what's called a dural tail sign, which I'll show you on another scan. And then as you saw in this case, you can have hyperostosis, meaning that it can actually promote bone growth above it. So benign tumors, all right, 32% of incidentally identified, meaning that, you know, people who go in for one reason or another have one of these. They don't grow over 3 years at all. And so the question becomes, if these are slow growing benign tumors, why do we operate, or what's the reason? And so there's two main ideas. Number one is it's causing a symptom, all right? And that could be weakness or numbness or seizures due to where it is, okay? Or it's growing. And if it's growing, it's going to keep growing, all right? And like we talked about the other day, there's only so much room in the skull for things, all right? And so if you have something growing that shouldn't be there, it can kind of crush or, you know, decrease the amount of other things. And so again, a benign grade 1 lesion is cured with excision, a gross total excision. And so, you know, we have a chance here to actually cure this person of their problem. Now, this isn't his scan. This is a case of mine that I wanted to show you guys. This is a right frontal, very classic meningioma, right? Homogeneously enhancing, right? Pushing the normal brain out of the way. This one happens to be causing a lot of swelling here, okay? And what we call midline shift. It's pushed the ventricular system completely out of the way. And so, needs surgery. I'm going to look at the chat real quick for a minute. Yeah. Oh man, so much chat. I love the chat. So yeah, symptoms wise, again, it depends on where it's located for the most part. And we'll talk about that. And then yeah, risk of recurrence without shaving the bone. That's right. Typically when you take the bone off like that, you've devascularized it. And so that bone will fuse ultimately and it could grow back, but for the most part it dies. We will shave it though, just like that. So on the scan here, this was all tumor. All the white stuff right here was tumor. And this person is cured and doing fine. Why do you use burr holes? Burr holes are used basically to access the dura because we need the bone to come off. So, all right, I'm going to keep going for a little bit, just to keep talking while they do their thing. So, what's our epidemiology here? So, this is 15 to 20% of primary intracranial tumors. I told you, most common benign tumor in the skull, right? 20% of anything identified. That's a huge number. Peak incidence is about 45 years old, all right? But we do see, you know, younger and older. And it predominantly affects women, actually, 1.8 to 1, almost 2 to 1 in women. And there are studies looking at estrogen receptors, progesterone receptors have to do with hormonal promotion of these things growing. And so those are known cases. We've seen these things grow during pregnancy as well, faster more than anything. Most common locations, so parasagittal, that's what we're dealing with in the other room right now. This picture up here is a similar parasagittal, although this one does not touch the superior sagittal sinus. It's lateral to that. So this is technically a convexity, okay, which is the second most common. Tuberculum sellae is right above the sella where the pituitary gland is, right here between your eyes. That grows at the skull base and pushes the brain up. All right, the sphenoid ridge is on the side of your eye, basically coming up here. And those are very common and very dangerous because they can involve things like optic nerve or carotid artery. Olfactory groove is also right between the eyes here in the skull. And then the falx is the center of the brain. The dura basically wraps up and goes right down the middle. And so what we're dealing with inside here is best showed in this little cartoon. The superior sagittal sinus is actually not a proper vein, but it carries venous blood. What it is actually two folds of dura create a virtual space like this. And the venous blood goes through that, and then that drains into a vein down at the bottom of the skull, all right, or in the veins that drain into it as well within the brain. But you can see the tumors start here in the arachnoid, and they push into it or infiltrate into it. And this is a grading system based on, you know, how involved the superior sagittal sinus is. But regardless, you have to be super careful. Pathology-wise, this is what we think about. So there's a number of different histologic types. The genotypes, the genetic analysis is just starting to be understood, and there's many variations in all of these things. It's extremely complicated, probably outside of the scope of what we're going to do here today. But if you're interested, look it up, read about it, or become a neurosurgeon and think about it and try to treat it forever. But these are the most common types. Meningothelial is the most common, fibrous, fibroblastic. These are cells with a lot of connective tissue. Transitional is something in between. Somoma bodies, these are, you know, essentially pathognomonic for meningioma when you have a lesion in the brain like this. And these are these circles that you see that look like targets. And this is actually dystrophic calcium that deposits in the tumor. When you see meningiomas become calcified over a long period of time, generally a suggestion of slower growth. And so you look for that on your scans. Sometimes these things can be hard as rocks. Tumor grades. Now this is where it becomes important. Okay, so a grade 1 tumor is benign. If you resect the whole thing, you cure the patient. All right, but there are variations on the grade, and none of them are really, you know, malignant except for a grade 3, but they become more locally aggressive. So an atypical meningioma has more mitotic activity. Mitotic activity, mitoses, right, is cell replication, basically cell duplication. Okay? And so with increased mitotic activity, it means that they're more aggressive. They're growing faster. They're replicating faster, okay? There's more cells in these. Sometimes they outgrow their blood supply and they can't get enough sustenance. So the beginning of them, the middle of them actually necrose, become dead tissue in the center. These are two more pathology-oriented things, giant cells and cellular atypia, but that just means abnormal cells. The cells look funny. The malignant type is our most feared type, right? This is a bad disease. These things have extremely frequent mitotic figures, meaning they replicate very, very fast. When I say greater than 4 per high-powered field, a pathologist takes this tissue and he stains it for markers of growth. And he looks at them in little fields that are a certain size. And basically, he counts how many mitotic figures he physically sees. And so greater than 4 would suggest rapid growth in this case. When you see brain invasion, if the brain is actually infiltrated, that's a sign of higher grade and more dangerous. And then if they come back fast, usually a sign of a poor prognosis. Now, we don't know what his is yet, and truthfully, we probably won't tell you guys anyway because we have to protect patient identities and rights and things. But it looks, you know, benign, and I'm sure it is. So, presentation, we talked about, some of you guys already asked. Most of these remain asymptomatic, all right? Symptoms depend on location for the most part. If it's at the skull base, it's going to act differently than in the skull top. You heard from Dr. Bookfar that in this guy's case, it's the hand that's causing a problem. He keeps having to shake it. He's got poor sensation, okay? That can develop into weakness. That can develop into seizures as well, especially if there was brain swelling, all right? That said, 40%, so 4 in 10 people who have these things don't have any symptoms whatsoever. And that's why, again, when you first get diagnosed with a meningioma, we're going to watch it. We're going to make sure it's growing before we offer you surgery. And if it's not growing, we're just going to continue to watch it because there's no urgency, right? Up to 30% are not going to grow in 3 years. So you basically have the wrong answer is to operate on every single one of these things. You want to really watch. You want to make sure that it's something nefarious that it's indicating. All right. Up to 70% don't grow at all over 3 years. That's a huge number, right? So again, watch. And then calcification we talked about, slower growth rate, right? So surgery, what are we going to watch today? So the initial, the kind of guideline for this is internal decompression. All right, you're going to soften the tumor up so it's not pushing on the brain. And then you're going to dissect the capsule when it's loose and free. All right, so you can safely remove it from the brain. You can kind of roll it into itself. And this is critical. This is putting pressure on the brain right now. So if you went to try to remove the whole thing, you're going to exert more pressure on the brain. So you decompress, and then you pull that capsule in. All right. Something called embolization, which I'm not sure if you guys have heard about yet or not. But embolization refers to going in endovascularly, so through the groin with a long catheter, and you're actually able to put glue in the tiny blood vessels that feed this thing. And that actually reduces the amount of blood flow to it, sometimes causes part of the tumor to die. It means that during surgery, you're going to have less blood loss, and it's going to be already kind of dead and suckable. You can kind of suck the whole thing out. Now, radiosurgery versus radiation. This is a treatment that's for recurrences, obviously. For lesions that are small, that are growing, you could potentially do this. Typically, we save this for someone who has had a surgery to get a diagnosis, and then it's growing back. And you use the radiosurgery to control the disease. And this is super effective, actually. Chemotherapies, to date, there are none. People obviously look at this. This would be great if there was something that could actually shrink the tumor size. But we're just not there yet. So generally, it's surgery and then radiation. All right. Here are how we measure outcomes. So there's surgical outcomes, all right, something called the Simpson grade, right? And the Simpson grade has to do with how much of the tumor you actually take off. So a grade 1 means you get the entirety of the tumor, and then you also resect a portion of the dura that's around it where it originated from, all right? And with a Simpson grade 1 resection, you should have a low rate of recurrence in a grade 1 tumor, all right? Grade 2, or Simpson grade 2, sorry, means that you take out the whole tumor and then you actually cauterize the dural attachment. And this is more used when you're talking about tumors with a skull base, where you can't really resect the dura because it's not exposed to you. It's attached to the skull. Sometimes nerves are going through it or arteries are attached to it. But you still have a good outcome with that. Grade 3 is you just resect it. You don't touch the dura at all. 4 is a subtotal, and 5 is just a biopsy. Obviously, those are riskier of recurrence because you never really got rid of it in the first place, right? It's not really a recurrence, it's progression. So with a total resection, again, 10 to 15% recurrence rate. Okay, not bad. 30% with the subtotal, because again, you didn't take out the tumor. It's still there. It's still growing. 5-year recurrence overall with a subtotal, 85%. So again, you have one chance to really do this the right way and get the whole thing out. 20-year recurrence, about 50% at the highest. I'm not sure if that includes with radiosurgery or not. And then obviously if it's malignant, you have an issue where it recurs more frequently. All right, so that's kind of the end of the slideshow. I'm going to check in with the OR and see what's going on there. Let me take a few more questions right now. Give me 1 second. All right, what do we got? Can we have access to these PowerPoints? Yeah, I'll send my PowerPoint along. That's not a problem. Yeah, tumor margin is the lining of the tumor. That's right. Again, extraaxial, which means that the pia of the normal brain is intact. This is pushing that away. All right. How do you soften the tumor? So embolization can do that, or sometimes they're just soft. I'll tell you that one of the tricks I learned in residency was there are 3 components to a tumor surgery, especially a meningioma, okay? Tumor location, tumor vascularity, and tumor consistency. So a hard calcified lesion is going to be harder to remove than a soft suckable lesion. A hard calcified lesion at the base of the brain location is going to be really hard to remove, okay? And then if it bleeds the entire time, you're just talking about danger. And so those are the 3 factors that I consider when I'm taking out one of these things. All right. Decompression, again, is you basically stay within the confines of the tumor and you scoop out the insides, kind of like, taking out a grapefruit. You've got the shell afterwards. You couldn't really squeeze that grapefruit initially, but if you empty out a grapefruit and then squeeze the peel, it's going to be a lot easier, okay? What is XRT? It's radiation, sorry. When the tumor shaved off, was that? No, we haven't sent any tumor yet in that case. Let's see where we are. Malignant transformation is possible, but rare, especially if you get a good resection initially. How long does it take the brain to go back to its original place? Probably realistically a couple months. Sometimes it'll inflate, it'll just pulsatile inflate, but this is, you know, you got to think about this, right? This thing gets to be 4.5 centimeters wide. Do you think that's rapid growth or do you think that's slow growth, right? Your brain can't tolerate it. If someone put a baseball in your brain immediately, you wouldn't feel good. And so these things grow slowly and they push the brain out of the way, and the brain gets accustomed to that. And so it's already accommodated if it's functioning fine. And so it takes a minute for it to re-expand. And there's always some defect there, without a doubt. Can a tumor in the frontal lobe show psychiatric symptoms? If it's just pushing, typically not. But if there is swelling, then absolutely. Is there a way to cure meningiomas without surgery? Not yet. Tumor location, vascularity, consistency. You're not going to find that in any textbook. Those are my 3 components, all right? That's something that people with a lot of experience taught me. Preoperative consistency of a tumor, you get an idea. So CAT scans and MRIs can show calcifications without a doubt. When you look at these things, sometimes they have T2 brightness on the MRI, which suggests there's a more fluid component to it, so usually a little more suckable. How do people with blood disorders such as hemophilia go through this? Well, it's dangerous, right? You have blood product in the room. We have blood product in the room here because this is a dangerous opening, without a doubt. Location, vascularity, consistency, how hard the tumor is. Sorry.
Hey, Dr. D'Amico.
Yeah.
I just want to be aware that we got like a minute or 2 left, and then
Yeah, so let me jump in real quick. And is Dr. Singh in yet?
yeah, he is.
All right, give me 1 second. I'm going to pull him back in for 1 minute. You can promote Dr. Singh. We'll talk to him too. How are we looking in here? We got tumor?
Not yet.
Pulling up. So Dr. Singh's coming in. Maybe we can just expose it and then we'll let them go. All right, guys, we're almost ready to show you what's going on in here. We'll keep going with questions. Let's see. How do you know when a tumor is inoperable? So that's a tough question, all right? There are different options. You could always debulk a tumor, okay? But
do they have
hey, Dr. Singh.
How are you guys? Can you see me?
We see your name, not you just yet.
Trying to make sure you guys.
We're just doing a session on meningiomas. We were live in the OR, and they're actually going to they're exposing it right now. I just want to show the students, and then I'll let Dr. Bookfar do the resection, obviously.
No
and then
problem.
we'll you go with your lecture. Thank you so much for coming along. I'm sure you can see, but we've got 1,065 kids watching right now. Let's see what we got. It's gonna just flop right. Yeah. All right. So, in the interest of time, we're gonna kind of move on to the lectures, okay, guys? This is fantastic, though. It's because we got to respect.